And now I'd like to introduce our moderators for this next section. Dr. David Lazar is an associate professor of surgery at the University of California, San Diego in California. Dr. Brielle Ochoa is a research resident at Phoenix Children's Hospital in Phoenix, Arizona. And Dr. Rachel Sundlin is a general surgery resident at Maimonides Medical Center in Brooklyn.
Wonderful. Thank you very much. And I'd like to wish a happy early Mother's Day to all of our mothers in the audience. Our first talk is entitled Acid Suppression After Esophageal Atresia Repair. Some Infants Do Benefit. And this will be presented by Suhail Zainadine from Lurie Children's of Chicago.
Thank you. That's a lot to follow. Esophageal atresia or tracheoesophageal fistula is a congenital anomaly that affects about 1 in 4,000 patients annually. With mortality rate decreasing, morbidity after repair has become of a lot of interest, as we've seen in this conference. Post-op stricture rate is reported as high as 40%, and a lot of people are trying to figure out ways to decrease that risk. One hypothesis is that gastric acid exposure can be associated with recurrent strictures and increase this risk. Most guidelines have advocated for continued acid suppression after repair for even up to 1 year and then reevaluate. However, recent studies have looked and contested the benefit of prophylactic acid suppression in these patients. Therefore, we wanted to look at the association between anastomotic stricture rate following esophageal atresia repair in those patients who received or did not receive acid suppression in a nationwide sample. For that, we performed a retrospective review using the Pediatric Health Information System, the PHYS database. We included patients with diagnosis and procedure codes for esophageal atresia and its repair between 2010 and 2022. We excluded patients with stricture during their initial admission because we wanted that as an outcome after a discharge. It also could affect prescribing, could influence how they prescribe acid suppression. We also excluded patients with length of stay less than 7 days based on our lit review and our data where those patients were kind of on the lower extreme of the range, just to account for some coding issues. Our main outcome was postoperative stricture, and our main predictors were acid suppression as well as disease complexity, which is a variable we proposed to kind of as a proxy for long gap or type A TF or something like that. We use descriptive statistics and multivariable regression for that. Just some definitions because we're using a database study. PHYS database has a lot of inpatient charges, and we have daily pharmacy codes. However, they don't have outpatient prescriptions. So we used daily inpatient acid suppression with a PPI or H2 blocker, including and up to and including the day of discharge. However, for those with prolonged length of stay, to account for some missing data, we included those with at least 30 days of acid suppression in the acid suppression group. In terms of disease complexity, which, like I said, is a proxy for long gap or type ATF or a leak, we included those with delayed repair 7 days or more after admission, or who had multiple fluoroscopic studies, or with very long length of stay, over 60 days. As far as postoperative stricture, we only were interested in those that were clinically relevant, so we only included those who underwent endoscopic dilation. And we included overall over 1,400 patients, about 2/3 were in the acid suppression group. There were no differences in age, sex, prematurity, age at repair, or type of repair. However, there were a bit more complex people in the acid suppression group. When we looked at the overall stricture rate, it was about 24%, and it was slightly higher in the no acid suppression group. However, when we broke it down to simple or non-complex and complex disease, we note that the majority of this difference was in the complex disease that did not get acid suppression. Then we tried to limit this at 1 year just to account for possible differences in follow-up, and we noted the same trend. On multivariable regression, we know that patients with complex CF with no acid suppression had about 80% higher odds of getting a stricture at 1 year. However, if you look at the second line within the box, the interaction term between acid suppression and the complexity of TEF shows that acid suppression cuts that risk in half. This is visual representation of Kaplan-Meier curve to show kind of the timing of when these strictures happened overall in our cohort. However, when we split it down on the left side of the screen, we look and we see that the lines are almost identical for those with acid suppression and without acid suppression with the non-complex group. However, on the right side, we do notice a significant difference between those who got acid suppression and those who didn't. We have limitations inherent to database studies and the lack of our knowledge of outpatient medication use. In conclusion, postoperative acid suppression seems to be associated with benefit for patients with complex esophageal atresia or TEF. However, consistent with other newer literature, we found that there's no association between stricture rate and acid suppression in patients with simple esophageal atresia. Prospective research is needed to confirm this finding and help inform practice change. Thank you.
This abstract is now open for questions.
How do you think that you'd be able to apply your findings in terms of the length of time that these patients should be prescribed acid suppression for?
So like the outpatient acid suppression. So based on this and other data, I would say that, well, like I said, we need prospective studies. I would suggest like one group would be with those simple TEFs, maybe not prescribe and see how that happens compared to groups. And those with complex disease, which was my original sentence there, but I was told to change it, is that we need studies to look at what duration is actually the most optimal.
Thank you.
Thank you. Our next abstract is entitled Outcomes of Primary and Delayed Sutureless Closure for Gastroschisis, and that's presented by Ranjit Kelsey from Pittsburgh.
Good morning. Thank you for the opportunity to present. I have nothing to disclose. Over the past several decades, the incidence of gastroschisis has been increasing across the United States. Over the past 2 decades, a plastic or sutureless closure has been utilized to treat patients with gastroschisis. There have been multiple studies comparing sutureless closure patients to primarily closed patients, and they found that these patients require less general anesthesia, decreased ventilator days, fewer infections, and an associated reduced need for antibiotics. Previous studies have also found improved cosmesis as well as a cost savings compared to primary closed patients. However, the literature is fairly limited when comparing a delayed sutureless closure to a delayed primary closure. Thus, we sought to evaluate outcomes of our patients with gastroschisis comparing primary closure to sutureless closure in both an immediate fashion as well as a delayed fashion. So we performed a retrospective comparative study at our institution evaluating patients that were admitted between February 2007 and October 2020. We sought to evaluate outcomes for those that underwent an immediate repair within 24 hours of birth and those that underwent a delayed repair greater than or equal to 24 hours after birth. And we compared a sutureless repair to a sutured repair with or without a patch. Primary outcomes that we looked at were mechanical ventilation, time to initiation of feeds, time to goal feeds. Secondary outcomes included time to closure, length of stay, wound infection, duration of central venous catheters, duration of antibiotics, and TPN days. We identified 280 patients with gastroschisis. We excluded 53 with complex disease. We excluded another 31 that were repaired elsewhere. The remaining 196 were stratified as follows: to an immediate primary closure group, an immediate sutureless closure group, a delayed primary closure group, and a delayed sutureless closure group. In terms of demographics and perinatal care, the majority of our patients were female, white, with an average gestational age of 36.3 weeks, average birth weight of 2,385.2 grams. Most were diagnosed prenatally, and most were delivered vaginally. Of note, UPMC Children's Hospital of Pittsburgh is not attached to a birthing center. So to facilitate these sutureless closures, we had to actually have a conversation with our local OBGYN teams and tell them the importance of preserving length of the umbilical cord as well as how to preserve the umbilical cord prior to transfer. And so this here is a typical immediate sutureless closure patient. Upon reduction of abdominal contents, we're able to use the umbilical cord to close the defect. In a typical or in a similar fashion, we treat our delayed sutureless closure patients where we first preserve their umbilical cord and we serially reduce their abdominal contents, typically less than a week, and then we're able to use the umbilical cord to once again repair the defect. In terms of average time to closure, in the immediate arm, the sutureless closure group was 2 hours faster, and in the delayed arm, it was 80 hours faster. In terms of mechanical ventilation, the sutureless closure group required 1.3 fewer days in the immediate arm and 9 fewer days in the delayed arm compared to a primary closure. Interestingly, there was no difference in the time to initiation feeds in the immediate arm or the delayed arm. However, looking at the time to goal feeds, in the immediate arm, the sutureless closure group attained goal feeds 5 days faster. In the delayed arm, they attained goal feeds 14 days faster. Looking at duration of TPN and central venous catheters, the sutureless closure patients, again, required a shorter duration in both the immediate and the delayed arms. Length of hospital stay was no different in the immediate arm between the primary closed patients and the sutureless closure patients. However, in the delayed arm, the sutureless closure patients, on average, were discharged 16 days faster than their primarily closed counterparts. In terms of wound infections, the immediate primary closure group had more wound infections than the immediate sutureless closure group. And then this also carried over to the delayed primary closure group compared to the delayed sutureless closure group. And so correspondingly, the primary closure groups required more or a longer duration of antibiotics in the immediate arm as well as the delayed arm. In terms of complications, there were very few intraoperative complications. There was no statistical difference between groups. In terms of postoperative complications, the majority were comprised of wound infections and necrotizing enterocolitis. They were slightly higher in the primary closure group and the sutureless closure group. In the delayed group, they were also much higher in the primary closure compared to the sutureless closure, but there was a statistical difference. Limitations: early in the study, all patients underwent a primary repair. Upon institutional acceptance of a sutureless repair, this became the repair of choice. This is a single institution study. It's a retrospective study, and there was a small sample size. In closing, a sutureless closure, whether it be a delayed closure or an immediate closure, we found it to be superior to a primary closure with improvements in mechanical ventilation days, time to attaining goal feeds, shorter duration of TPN, shorter length of needing a central line, shorter hospital stay, and fewer wound infections. These are my references, and thank you for your attention.
Thank you very much, and we have a question.
Great work. Thanks. It's very important data, especially for somebody like me who has trouble convincing his partners that this is the right way to do things. I just wondered if you could clarify how you're preserving the umbilical cord. It sounds like a conceptually easy thing, but we've had some pretty gross umbilical cords.
Yes. Thank you for your question. So in terms of preserving the umbilical cord prior to transfer, we've instructed our OBGYN friends to basically just apply some moistened gauze around the umbilical cord prior to transfer. And then in the delayed sutureless closure arm, we essentially place the umbilical cord into a colostomy bag and also apply moist gauze over the umbilical cord during that week of reduction.
Thank you for a good presentation. Pramod Puliana from Montreal. I'm glad that this is getting a bit more traction. We've been doing sutureless closure for a few years now. I was just curious, is the protocol, or were you able to discern whether all infants were intubated for the sutureless closure, or was there a population of infants that you were actually able to reduce without intubating the patient?
That's a great question. I'm glad you asked. There was actually a fair number of patients that we were able to perform a sutureless closure without mechanical ventilation.
Great. Augusto Zani, Sick Kids in Toronto. We also have experience with the sutureless closure, and my question is more with regards to the long term. Some of these babies, quite a few in fact, develop an umbilical hernia. In our experience, and we also reported it, it will close spontaneously. You don't need necessarily to operate on them, but there's some people that still don't believe in the sutureless closure and bring that up as a downside. Do you have any data on that?
So a small number of our patients did develop umbilical hernias. I don't know the number off the top of my head, but it was fairly small.
Did you have to operate on those?
Yes.
Thank you.
Mhm.
Great. Thank you very much. Our next presentation is entitled "The Short-Chain Fatty Acid Butyrate Ameliorates Necrotizing Enterocolitis and Inhibits Exaggerated Bacterial Signaling in the Premature Intestine of Mice and Humans." This will be presented by Andres Gonzalez Salazar from Johns Hopkins.
Good morning, everybody. Thank you so much, Dr. Lazar, Dr. Ochoa, and thanks to ABSA for the opportunity to present our work. I have no financial disclosures. So necrotizing enterocolitis is a disease that we often find in our line of work, and it creates a lot of issues when it comes to the lifestyle and health of our population of neonates and infants. And I'll be talking a little bit about the pathogenesis of the disease today. And this is a graph that I very much like, and it summarizes all of the factors that come into play when it comes to the development of NEC. And in the top, we have prematurity. And the big question that we have when it comes to necrotizing enterocolitis is what in the premature gut, in the intestinal epithelium of these babies, promotes or creates the environment that leads to the injury that we see in this disease process. In this graph, we also see that there is a dysbiotic component of the microbiome in the gut that can also affect, and we know as well that the nutrition feeding formula often initiates this process, while breast milk tends to provide a protective factor. In our lab, we work with the theory that TLR4, toll-like receptor 4, is a major component that leads to the development of necrotizing enterocolitis. We know this receptor as one of the components of the innate immune system and recognizes or senses LPS. And in that premature gut, we see that TLR4 is overly expressed, and when in combination with the dysbiotic microbiome, we can see a perfect window into the development of the disease process that we see. But still, we have that question of how nutrition can link all these three factors together. And that led us to short-chain fatty acids. So short-chain fatty acids are metabolites, very fundamental particles that have been studied a lot when it comes to energy metabolism and also to the development or modulation of the immune response. And interestingly, these are produced by our own gut. So we see once we have fibers that our gut cannot digest, the microbiome, the bacteria, ferments these carbohydrates and then produces or increases the concentration of short-chain fatty acids. And interestingly, we see that the bacteria of healthy gut of the mature infants that have been breastfed, these are the ones that tend to produce or create these metabolites. So that led us to the question or the hypothesis in our study. Butyrate, one of these short-chain fatty acids, can reduce intestinal inflammation via TLR4. And the methods that we use in order to find this is, first, we differentiated or created intestinal organoids from human stem cells. We induced inflammation with LPS targeting that TLR4, and then we also treated with butyrate to assess the response and the expression of pro-inflammatory cytokines. And we also used our trusty neck mouse model in order to see the effects on an animal model of neck. These were supplemented with butyrate as well. And here we see our results. So initially in the intestinal organoids, we see how IL-6, a pro-inflammatory cytokine, the expression increases when exposed to LPS and is decreased when exposed to butyrate. And in our neck mouse model, we see the same trend with TNF-alpha as a pro-inflammatory marker, and then a decrease when butyrate is added to the formula. We also see the same results when it comes to the histologic injury scoring. But the most important slide, and this is the first time we have seen this, is that TLR4 expression also decreases when adding butyrate to the group that is treated with this supplement, which follows the question of how the interplay of nutrition, the microbiome, and the intestinal epithelium works. So in conclusion, we can see that butyrate decreased that inflammatory response both in organoids and in our neck mouse model, and that the potential way or pathway that this is working through is through decreased expression of TLR4. Thank you so much, and I am happy to take any questions.
Thank you very much, and abstract's open for discussion.
Gail Besner from Nationwide Children's Hospital. Thank you for another example of the fabulous work that is coming out of the HACM lab to try to figure out a solution for this disease. And I was just wondering if in your animal model, have you had the opportunity yet to actually characterize the intestinal microbiome? And if so, what were your findings? Thanks for a great talk.
Thank you so much, Dr. Besner. Yeah, that's part of the next steps that we're working on. I think it's very interesting to see how both the premature gut and the mature gut, the differences when it comes to the microbiome. And when we are generating our neck mouse model, we give formula that has bacteria that was obtained from samples of stool of patients with neck. And so when we add that formula or feed that formula to the mice, their microbiome definitely changes. That's what induces the expression. But these differences between the mature gut, the premature gut, and how the different population of bacteria changes between them is something that we find very fascinating. Thank you.
Dr. Sandlin?
We have a virtual question. Do you propose to use butyrate as a prophylactic treatment to all infants prior to neck diagnosis or after diagnosis as a treatment?
That's a great question. Although our study does not go into the aspects of timing when it comes to when to give these supplements, I think one thing that is particularly important is all the developments and the studies of probiotics as potential treatment for neck. And probiotics have been given before, both in terms of prophylaxis and also during the development of neck. I think importantly with these disease process, I think finding something that can be not harmful for these very, not very stable patients is something that is very important to us. But to answer the question in a more succinct way, I think the important aspect of this is to make sure that the profile doesn't affect when it comes to prophylactically treating these patients.
Thank you.
Wonderful, thank you.
Thank you.
Our next presentation is entitled Percutaneous Ultrasound Guided Peritoneal Access with a Central Venous Catheter as a Temporary Method for Peritoneal Dialysis. This will be presented by Daniela Padilla Alanese from Monterrey, Mexico.
Thank you. So acute kidney injury affects between 10 to 24% of all pediatric and neonatal patients hospitalized in an intensive care unit. The techniques of peritoneal dialysis, as we know, catheter placement include open or laparoscopic surgery or a percutaneous approach. So we present a technique of percutaneous ultrasound-guided placement of a central venous catheter as a temporary method for acute peritoneal dialysis. We carried out a retrospective study of patients hospitalized in an intensive care unit in Monterrey, Mexico. All patients were in critical condition and required urgent peritoneal dialysis. Due to the conditions, they were unable to be transferred to the operating room, and procedure was performed at the bedside. We performed an abdominal pre-procedure evaluation with a Micromax ultrasound transducer to scan for ascites and location of a puncture site. The greater the distance from the intestinal loops, the better. We used a long axis view and in-plane approach to insert a needle in an oblique angle to form a subcutaneous tunnel. In this video, we can see how the needle tip is located to identify the peritoneum by deforming it, and then we can see like a phantom in the lower area that confirms the catheter is in the peritoneal cavity, and we can confirm that by moving the transducer, sorry. Using the Salinger technique, we insert the catheter to the pelvic cavity. So after we confirm the correct position of the catheter, we fix the catheter with a 3-0 silk and adhesive patch. An abdominal X-ray was then performed to confirm the location to the peritoneal cavity. In cases where no ascites was present, ultrasound-guided puncture was performed using a short axis view, and we used a 22 intravenous catheter within 10 to 20 millimeters of saline infusion to increase the volume of the intraperitoneal fluid. Our results, ultrasound-guided catheter placement for peritoneal dialysis was completed in 6 patients, 5 of them girls and 1 boy. The mean age was 27 days. 3 of the patients were pre-diagnosed with a congenital heart disease, and 3 were pre-diagnosed with sepsis. The mean time for catheter placement was 15.7 minutes, and in 2 patients that needed saline infusion, placement times were 20 and 22 minutes respectively. The catheter was used for peritoneal dialysis for a mean time of 2 days, but catheter would remain functional and in place up to 10 days. The motive for using the CVC catheter for peritoneal dialysis is our lack of appropriate size tank of catheters. In our patients, because the event was acute, the need for emergency peritoneal dialysis was only for a short time, and peritonitis did not occur. The use of this type of catheter, however, is a risk. In the case of required extended renal replacement therapy, once the patient is stable, the exchange from the CVC to a tank of catheter should be considered. In conclusion, in our experience, percutaneous ultrasound-guided CVC placement in the peritoneal cavity for acute dialysis is a safe, quick, and simple bedside procedure. Thank you.
Great presentation. Were there any issues during the catheter placement that you needed to troubleshoot? I know you said there's no catheter dysfunction, but were there any issues with these patients where you had to change the technique as you went through?
No, there were no problems. We used the ultrasound, and that helped us a lot.
Great. You have a question?
Hi, Abigail Martin from University of Kentucky. Thank you very much for that presentation for addressing a very, very difficult problem. I was wondering if you could comment on how you performed the exchanges, whether they were done manually or whether the patient was then on some type of continuous exchange machine.
They were manually. We did it manually.
Great. Thank you very much.
Thank you.
Our next presentation is entitled Pediatric Neck Vessel Repair Following ECMO Decannulation. Is it worth the risk? This will be presented by Tanya Janelle from Columbia University.
Good morning. Pediatric ECMO patients that are cannulated via the neck for ECMO support peripherally have the option to undergo either repair of their vessels, their common carotid artery, or their internal jugular vein, or ligation at time of decannulation. While there are well-described advantages and disadvantages for both of these options, there seems to be a significant practice variability both within and among pediatric ECMO centers. The purpose of our study was to examine vessel patency and evaluate vascular complications that occurred post-repair, including stenosis, dissection, and pseudoaneurysm. Additionally, we wanted to evaluate the ischemic CVA rate following vessel repair in peripherally cannulated patients that underwent vessel repair and compared this to ligation. This was a single-center retrospective review of pediatric ECMO patients cannulated via the neck for VA ECMO support from 2009 to 2022. Vessel patency and vascular complications were determined by post-repair vascular imaging that included ultrasound as well as CT. Cerebrovascular accident was detected by decannulation, imaging in patients who demonstrated neurologic deficits on exam. Our study population consisted of 181 patients that required ECMO support. 100 of these patients needed ECLS for cardiac reasons, with the remainder needing support for respiratory reasons. The median age at cannulation was 19 days, and most of these patients, for the median duration, was 5 days of support. Of this study population, 135 survived to decannulation, with 52% surviving to discharge within this cohort, on par with ELSO survival. When we examined vessel repair, 47 of these patients that survived to decannulation underwent vessel repair. The majority of these patients underwent repair of both of their vessels, with the remaining 38% only undergoing repair of their artery. When we went back and looked at the patency rates, 66% that had imaging of those that underwent repair had a 90% rate of their common carotid artery being patent, with a 64% patency rate of the internal jugular vein. We compared CVA rate in both of these populations. Patients that underwent vessel repair was obtained imaging-wise in 25 of these patients, with those that underwent artery repair. CVA occurred in 4 of these patients. Brain imaging was obtained in 51 patients that underwent ligation, and CVA was noted to occur in 2 of these patients. The limitations of our study include its retrospective nature and a recent implementation of our post-repair imaging protocol. At our institution, there is not a standardized protocol for evaluating neurologic outcomes, and this leads us to not have a lot of long-term data. In conclusion, we demonstrated excellent patency rates of the common carotid artery and the internal jugular vein in the short term, defined as less than 1 year, at 90% and 64% respectively. Patients who underwent carotid repair did have a higher rate of ischemic stroke compared to those that underwent ligation. However, this was not statistically significant. This brings me to my next point, which brings light to the fact that we have a very high population of cardiac disease in our hospital. 81% of the patients that underwent vessel repair had congenital cardiac disease, and repair of the vessels offers an opportunity for these patients that might require future ECMO runs. It would be advantageous in this population particularly. Further studies are necessary to evaluate long-term patency and neurologic outcomes. Thank you so much, especially to my team at the hospital and Dr. Middlesworth, who held the ECMO phone so I could come here.
Thank you, and we'll take some questions.
Thank you. Nice presentation, Pramod Puliyan from Montreal. Did you have a standardized anticoagulation protocol post-repair, and what did that entail? We've been doing this now for a couple of years, where we've kept low-dose heparin, transitioned to enoxaparin, and then kept them on aspirin for up to a year with frequent ultrasound evaluation. But I'd be interested to know what anticoagulation protocol you used.
That's a wonderful question, and I actually did look back at our data, and so we typically transition patients from heparin to Lovenox and aspirin, and that was decided on a 3-month course. Patients that were higher risk for bleeding, such as CDH patients, for example, or were deemed to be higher risk, were not on that regimen, but we don't have any standardized protocol as of yet.
Hi, thank you for your talk. Russ Hawkins from Gainesville. The decision to repair, was that mostly surgeon dependent, or how long the patient was on their ECMO run?
A bit of both. We tended to find that in our center, the patients that had longer runs did not have vessels that were amenable to repair, which was discovered at time of decannulation. Typically, the cardiac patients had their repair done in tandem with their cardiac surgery, so that was beneficial from that perspective, but our pediatric surgeons do vessel repair as well.
We have a virtual question. What were the weights of your patients, and was there a difference in the groups?
I think the average weight was about 3.2 kilos, but I would have to go back and double check that.
Great. Thank you very much. Our next presenter unfortunately couldn't make it this morning. That is the talk entitled Surgical Management of Neonatal Severe Hyperparathyroidism. He can be reached through the app or email with any questions. So that will bring us to our next presentation, which will be the Association of Age, a Duodenal Atresia Repair with Outcomes, a Pediatric NSQIP Analysis. And that'll be presented by Shale Mack from Thomas Jefferson and Nemours Children's.
Hello, my name is Shale Mack. I'm a fourth-year medical student. Thank you for the opportunity to present. Duodenal atresia, or DA, is associated with several other congenital anomalies, namely trisomy 21, which is present in up to 30% of all patients with DA. Conventionally, DA is managed via duodenostomy in the early neonatal period. Many infants with DA are born prematurely, and moderate prematurity is associated with worse perioperative outcomes. Due to the limited urgency for DA repair, there's an option for delaying surgery, which may allow for growth of the infant or to address other congenital anomalies or comorbidities first. However, evidence-based recommendations are currently lacking for the timing of repair for DA in premature neonates. We hypothesize that although premature neonates are at increased risk for complications after DA repair, delaying surgery may not mitigate this increased risk. We utilize the pediatric NSQIP database from 2015 to 2020, identifying infants with DA through ICD-10 diagnoses codes and those who repaired within the neonatal period. We defined early repair as neonates who underwent DA repair within 1 week of life. Within the NSQIP cohort, neonates who were born at 35 weeks of gestational age underwent early repair about 92% of the time. Decreasing rates of early repair were seen with decreasing gestational age. Thus, we wanted to study this inflection point, analyzing neonates born at less than or equal to 35 weeks, comparing early and delayed repair. We performed a 1-to-1 propensity score match analysis on 2 key preoperative variables of gestational age and weight at birth. Our propensity match analysis resulted in 38 neonates in each group. Of note, the median gestational age at birth was 33 weeks in both groups, and there were similar birth characteristics. The median age and days of life in the early repair group was 2 days versus 16 days in the delayed repair group. The median weights were 1.6 and 2 kilograms in the early and delayed repair groups, respectively. There were no significant differences noted between groups in ASA classification, previous cardiac surgery, cardiac risk factors, or preoperative ventilator dependence, amongst other comorbidities. Composite morbidity was our primary outcome, which was a compilation of several postoperative complications all into one variable. These included the variables listed on the right, including but not limited to surgical site infection, wound disruption, sepsis, transfusion, and reoperations. The early repair group had a composite morbidity rate of 18%, and it was 26% in the delayed repair group. This was not statistically significant. Looking specifically at outcomes, the only significant difference between groups was days of postoperative mechanical ventilation, which was 2 versus 6 days in the early and delayed repair groups, respectively. There was no significant differences in postoperative length of stay, transfusion requirements, unplanned reoperations, and 30-day mortality. Of note, reoperation is the best proxy within the NSQIP database for technical failure, such as anastomotic leak or stricture, and there were no significant differences between the groups. The majority of these reoperations were exploratory laparotomies. The limitations of the study include that we are limited to 30-day outcomes, and certain complications such as anastomotic failure, megaduodenum, or dysmotility may occur after 30 days. There is also no CPT code specific to DA repair. However, we matched those with a DA diagnosis with CPT codes consistent with a DA repair, and we were possibly underpowered to show differences with 38 neonates in both groups. In conclusion, our study demonstrated no differences in short-term postoperative morbidity between early and delayed duodenal atresia repair in premature neonates born at less than or equal to 35 weeks. Further, delaying surgery did not appear to mitigate the risk of undergoing a surgical procedure in these premature neonates, particularly as reoperation rates were similar between both groups with significant differences in age of days of life at surgery. Thus, we recommend that it may be reasonable to consider an early repair in neonates less than or equal to 35 weeks of gestational age at birth. In our study, it appeared safe to complete an early repair in a cohort with a median corrected gestational age at surgery of 33 weeks and a median weight of 1.6 kilograms. Further study is warranted, including possibly prospective study, to look at long-term postoperative outcomes and to ensure that early repair remains safe in the long term. These are our references. Thank you, and I'm happy to take any questions.
Very nice study. I think this is a clinical question that a lot of us wrestle with when we have these premature infants that are born with duodenal atresia. One question I had, and I think you probably answered it in your limitations slide, but were you guys able to query the database as of the operation the baby got? Ideally we try to do a duodenostomy, but sometimes if the anatomy is not ideal, we perform a different bypass, like a duodenal jejunostomy. I'm wondering if any of that data was mineable in the database.
Yeah, so we could look at CPT codes, and they varied widely for the operations these neonates went. These 5 or 6 operations listed are the main categories that were grouped, and we went through each one to make sure that it aligned with what a duodenal atresia repair may be.
Dr. Sullivan? We have one virtual question. Based on your study, what is the current practice at your institution for DA repair in premature neonates?
Thank you for the question. So this study actually stemmed from a patient at our institution who was born prematurely at 32 or maybe 33 weeks. And there was debate amongst the attendings at our institution of when to repair this. Now, after this study and speaking with my attendings, it appears that they may be more comfortable with doing an early DA repair in neonates with moderate prematurity from 32 to 34 weeks, but typically early repair after that with 35 weeks plus.
Excellent.
Thank you.
Thank you very much. Our next presentation is entitled Predictors of Poor Growth in Neonates with a Small Bowel Stoma, and this will be presented by Martina Mudry from British Columbia.
Good morning. An enterostomy is often required as a temporary measure after intestinal resection in newborns with small bowel disease, such as necrotizing enterocolitis, volvulus, or complex gastroschisis. These infants frequently rely on parenteral nutrition when the stoma is present due to excessive fluid and nutrient losses from the small bowel.
Although PN is necessary for growth and development, it can be difficult to predict how well the PN will be tolerated and how well infants will grow despite maximal nutritional support. In many instances, length of the remaining small bowel is the best predictor of how soon an infant will achieve enteral autonomy and how well they will grow. However, there are exceptions. Some infants with seemingly sufficient bowel length have poor growth and failure to thrive. Intestinal health after surgery is also an important consideration. There is variability in the function of the gut, which makes it much more challenging to predict growth and the ability to wean from PN. Factors felt to affect intestinal health include gestational age, the underlying intestinal pathology, degree of residual inflammation, ability to receive enteral nutrition, and intestinal microbiota. The purpose of this study was to compare factors such as intestinal microbiota, stool energy losses, metabolic byproducts including short-chain fatty acids and bile acids, as well as PN support, and to determine their effect on gut function and infant growth. There were a total of 18 infants included in the study from 2018 to 2020. These were infants that had a small bowel stoma following small bowel resection. 48-hour stool collection was performed prior to stoma closure when enteral nutrition had been maximized. 16S rRNA sequencing was performed for microbiota analysis, and bomb calorimetry was performed for the analysis of energy losses, short-chain fatty acids, and bile acids. There were a total of 18 patients, and the median age was 28 weeks gestation at birth. They were a median of 8 days old at time of surgery, and diagnoses were variable. The patients were a median of 70 days old at the time of stool collection. The length of small bowel was a median of 49 centimeters to the stoma, which was 43% of small bowel remaining. Antibiotic exposure was similar in all patients. 6 out of 18 patients grew poorly with failure to thrive. Now, Z-score is a measurement often used to describe growth and represents the number of standard deviations from the mean. And when describing failure to thrive, moderate malnutrition is defined as a Z-score less than -2, and severe malnutrition is defined as a Z-score less than -3. And we can see here that this group of patients with poor growth had significant malnutrition with Z-score for weight of -2.95 and Z-score for height of -4.43, which is considered severe. When comparing patients with adequate growth to those with poor growth, we found that there was no difference in their small bowel length, stool energy losses, stool short-chain fatty acids and bile acids, or parenteral nutrition support. However, there was a significant difference in intestinal microbiota, with 90% proteobacteria and 10% firmicutes present in infants that grew poorly. The importance of intestinal microbiota and overall gut health and metabolism is becoming well recognized. In the setting of intestinal inflammation, there is a decrease in microbial diversity and a shift toward a higher abundance of aerotolerant anaerobes. On the other hand, in patients that have adequate growth, their intestinal environment has little inflammation with abundant anaerobes. But why does this happen, and how does this happen? Is the environment responsible for the lack of growth, or is it the other way around? Does poor growth cause a pro-inflammatory, hostile intestinal environment? This study confirmed that some infants with small bowel stomas have poor growth despite adequate intestinal length and nutrition. Based on our findings, we conclude that intestinal microbiota enriched in proteobacteria and deplete in firmicutes may impact metabolism and energy use, resulting in poor growth in this population. This leads us to future steps, which would be to alter the intestinal environment with targeted therapy for patients based on their individual microbiome to promote a healthy metabolism and growth. I'd like to thank Dr. Hannah Piper and the team at BC Children's for giving me the opportunity to present their work, and I'd be happy to answer any questions.
Thank you for that study. I think that's a very important clinical question that we all encounter at one point or another. I'm curious if you have any data on the infants that had poor growth and whether their poor growth was corrected once the bowel was put back into continuity. Often the argument against taking those infants to the operating room is that by being in a state of malnutrition, they will have a higher rate of surgical complications potentially. And so I was wondering if you could comment on that, and if so, did you observe an improvement in their growth, and did you see an increase in surgical complications or not?
That was not a part of this study, but a very important question that you bring up, and I believe it is part of future studies that the team is doing. So thank you for that.
I have a question. Is firmicutes a common ingredient in probiotic formulations? And of course, I know the answer. I'm just asking for the audience.
I'm not sure, actually.
Okay. Does anybody know? It's interesting. Interesting findings.
I think you alluded to this a bit in terms of the next steps, but for treating these patients, would this be enterally delivered, or is there kind of any other therapies that are out there that people are talking about in this field?
There are some other therapies other than probiotics. There are prebiotics, which is basically when you provide a fiber that the bacteria can utilize for growth. So the hope for future projects here is to identify each microbiome specific to that individual and figure out what prebiotic their microbiome would benefit from.
I have a second question for you as well. Do you foresee, in terms of like the logistics of, obviously collecting the stool isn't too difficult, but in terms of the analysis of stool to look at the microbiome, where are we in terms of that being something that we'd be able to do for patients? Is that still very costly? Is it time consuming right now, or is it a little quicker?
It's becoming quite good. There are companies that are now creating little vials that you can actually send to patients, and a little tiny spatula, so you can, it's a small sample, and then they're able to use that vial, which stabilizes the stool, to actually do the microbiome analysis. So the technology is definitely improving on that.
Wonderful. Thank you very much.
Thank you.
Okay, our final presentation of the session is entitled Diagnostic Accuracy of Laryngeal Ultrasound for Evaluating Vocal Fold Movement Impairment in Children. This will be presented by Sean Izzadi from Boston Children's.
Thank you for the opportunity to present. Surgeons often say that a chance to cut is a chance to cure. But when it comes to cervical, thoracic, or cardiac surgery, there lies an inherent risk of injury to the recurrent laryngeal nerve, leading to vocal fold movement impairment, or VFMI. And unfortunately, VFMI has a wide degree of presentation, from those that are symptomatic, such as with dysphonia or stridor, to those that are completely asymptomatic. And this creates difficulty in the creation of screening protocols. For example, who do we screen, when do we screen, and how do we screen them? Previous work from our group looked at preoperative patients at our esophageal and airway treatment center and noted that 1 in 4 were diagnosed with VFMI. And of those that were diagnosed, almost half of them exhibited no classic symptoms of vocal fold movement impairment. And interestingly, 1 in 5 had no previous history of at-risk surgery. Because of this, our institution implemented routine screening both pre and post-operatively, and we utilized the flexible laryngoscopy, which is the current gold standard for diagnosis. And in case you haven't seen a flexible laryngoscopy in a pediatric patient, it goes something like this. This is our gold standard. As you can see, in the pediatric population, this can be a pretty poorly tolerated procedure. And then you add in the movement burden, the secretion burden, and it makes the physician's life very challenging to come up with a diagnosis. Especially in patients with esophageal atresia or cardiac comorbidities, you run the risk of hemodynamic and respiratory instability. And in the COVID-19 era, you have to take into account that it's an aerosolizing procedure. Laryngeal ultrasound has been described as a potential alternative, but unfortunately, only small underpowered studies have been performed and none in the complex pediatric surgical patient. Because of this, we set out to evaluate the diagnostic accuracy of laryngeal ultrasound compared to the gold standard flexible laryngoscopy in the diagnosis of vocal fold movement impairment. We carried out a prospective single-center, single-blinded cohort study from 2021 to 2023, where we took perioperative pediatric patients and had them undergo both a laryngoscopy and an ultrasound. We were able to capture 85 total paired evaluations where we saw a VFMI prevalence of 27.1% in line with our previous findings. Although we stratified between optimal and suboptimal ratings of the ultrasound, we were able to combine these results in the end because of our promising results, as our overall agreement between ultrasound and laryngoscopy was 98.8% with a kappa of 0.97. Our sensitivity was 95.7% with a specificity of 100%. Our negative predictive value, 98.4%, with a positive predictive value of 100%. Of note, our only incorrect in our cohort was a false negative. We did do subgroup analysis looking at things such as age, diagnosis category, surgical approach, and even time between the studies, and noted that there was no statistically significant difference between those, lending ultrasound to be used in a wide array of cohort. Now here will be an example of a bilaterally normal vocal fold motion with the red circles around the vocal folds and the blue circle around the glottic opening, and you'll be able to witness normal abduction and adduction of the folds. And now you'll witness its paired scope. Now we'll see an example of abnormal vocal fold motion where one side is immobile. And now you'll see its paired scope. In conclusion, we've shown that laryngeal ultrasound is an excellent and accurate screening tool for the diagnosis of vocal fold movement impairment. And in our cohort, we had no cases of clinical decompensation, and it was very well tolerated. Because of this, we recommend routine use of the ultrasound for perioperative screening. And we know the implications of this are far and many, as VFMI contributes to respiratory morbidity in the pediatric population, and knowing the VFMI status allows us to change our management of these patients. Having the ultrasound available to us allows for a more accessible tool for broader screening, and it will minimize the invasive aerosolizing procedure and save the laryngoscopy for either confirmation with a positive ultrasound or for diagnosis of other known airway pathology. Thank you, and I'm happy to take any questions.
Thank you very much. It seems like the adoption of this ultrasound should be a no-brainer, given the accuracy and the minimally invasive nature of it. Can you describe the learning curve that was associated both in performing the study by the techs and then reading the study by the radiologists?
It's a great question. I think that's the biggest hesitancy in this, is that people wonder about that learning curve. Originally, it started with our radiologist performing all the exams herself, but then it became such a burden that she taught her 5 sonographers in an afternoon. So a very quick learning curve. Obviously, they're more experienced. But our ENT colleagues also have partners at other institutions that do this themselves, and they say that it's a very quick and easy learning curve. And as you can see, just having the right window on the ultrasound, you get a great view of the folds.
Yeah, thank you. All right, thank you very much.
Thank you.